So thank you for asking me to speak here today. As Brian mentioned, I'm a geriatrician, and so obesity is not usually my area of expertise because most of my patients, the problem is actually that they're malnourished and underweight. But since coming to work in Logan, as you've heard throughout the day, it has been something that I've had to learn as I've gone along. So I thought I'd just structure the talk with a brief case presentation, then just a brief summary of the evidence around obesity and acute surgery, because most of our work in the perioperative medicine service in Logan is with the acute surgical unit. Then just because I am a geriatrician, obesity in the older patient, because I really can't leave my older patients out of it, and then some time for questions at the end. So this is a case Martin Wolschlager and I shared. As you can see, she's not my usual age demographic, but the perioperative general physician was away, so I went to see her. She's a lady who had an uncomplicated hernia repair in theatre. And as you can see, her background history includes morbid obesity. She'd had a lap band, which, given that she's still at a BMI of 53, could be said to have failed, and had had an ICU admission with a pneumonia and was being investigated for obstructive sleep apnea. So before the operation, her oxygen concentrations were completely normal, and she really had an uneventful surgery, although she had episodes of desaturation throughout the case. And the anaesthetist looking after her had just commented that maybe some overnight oximetry should be done. But day one post-op, Martin came running towards me saying her SATs were 70% and could I please come quickly to see her. And we had a lady sitting very comfortably in a bed looking at us and wondering what all the fuss was about, whose SATs were 70%. And what was interesting was, being a physician, you just change fingers and hope that the oxygen saturations improve, but they didn't. And then I did a blood gas because I couldn't believe that someone who was sitting so comfortably like that could have SATs in the 60s. And as you can see, she had compensated respiratory acidosis. And I say it's compensated because she had a bicarb that was slightly up, and if any of us had a PCO2 of 68, we wouldn't be able to maintain mentation. She was normal. Having a PO2 of 38, however, is not normal in any stretch. So I thought her chance of having a PE was very low, but I think you have to exclude it in someone who's post-operative. And it showed some possible ground glass changes, so we asked ICU and the respiratory team to come and see her, and at the same time we got the results of her sleep study, and as you can see, her apnea-hypopnea index was 150, when greater than 30 is considered severe. So the respiratory physician who saw her worked out she had about 8 minutes of sleep a night. And we actually got more history afterwards. The reason her lap band had failed was that she'd had the lap banding but never had her obstructive sleep apnea treated. So she was a mother of a 3-year-old and used to drink energy drinks. She was drinking about 15 cans of Coke or Monster a day to try keep awake so that she could look after her child. So it actually shows that while you might need to do the surgery, bariatric surgery, she actually didn't have her sleep apnea treated. So she did well after going home with the respiratory team on CPAP. So as a perioperative physician, I divide the work in surgery into preoperative work, intraoperative, which really physicians have very little to do with, and postoperative issues. So I think the preoperative assessment of obese people is often quite challenging, and certainly from what I hear from my surgical colleagues, assessment of an acute abdomen in a severely obese patient is quite challenging. There's good literature around injury patterns, post-blunt trauma in obese people being different. And just even as a clinician, as a physician, you can't assess many of these patients' jugular venous pressures. They often have venous peripheral edema, so assessing their cardiac status and fluid balance is very challenging. And imaging may not be as helpful. Often ultrasound scan images are not as useful in this group, and echocardiograms are often of very poor quality. I did have a patient in Ipswich, not Logan, Ipswich, who was too large for our CT scanner. So that was certainly the CT scanner took up to 250 kilograms. So the preoperative medical assessment, I think in an obese patient, like every patient, it really depends on what's wrong with the person. And if the patient has fecal peritonitis, is septic and is shocked, it really doesn't, your assessment is they need to go to theatre if they're going to go to theatre. And most of the time for me, it's still about fluid balance assessment, sepsis control, which is usually done by the surgeons, but looking for other sources of sepsis, like in an older patient, have they aspirated? Management of arrhythmias and atrial fibrillation is common in this group. blood sugar control, and there's very few type 1 diabetics are morbidly obese, but in type 2. And then assessment of their cardiorespiratory function. And in the older age group, certainly I try to do some advanced care planning so that you're looking at what's the ceiling of care that's appropriate for the patient before you even go into theatre. I try to hand over to the anaesthetists, and that's sometimes a challenge because I think anaesthetists are caught in other cases and we don't get to see them. But where possible, I think that's good practice. And I tried to find some evidence around the physical toll on surgeons from operating on obese people, and there's actually very little literature around because I can just imagine the mechanics of trying to operate on someone whose BMI is 50 and how you have to lean over them and how your instruments have to be held. And I think that's probably an area that there's a huge gap in research for surgeons. Obese people use ICU more. So in the studies quoted, 58% of obese people went to ICU post-op as opposed to 42% of non-obese. Now, I don't know what exact surgery they were doing that 42% of their patients were going to ICU, but I think it really depends. You know, if your patient came in shocked, the chances of them not going to ICU after an operation is pretty low. But if you're obese, you've got a higher chance of going. And the super obese have a longer length of stay in ICU in a single center study. There's definitely a link between being obese and risk of surgical site infections. I'm sure any of you know this. Interestingly, the literature seems to suggest it's around increasing clean contaminated, and there's not much difference with contaminated wounds. I don't know whether that's something you find in practice. And then I think the link with mortality is pretty tenuous. So the study there about the adjusted odds ratio for mortality with obesity and trauma was 1.6, but being over 55, your odds ratio was 3.6. And having a very severe injury, your odds ratio of death was 9.7. So I think obesity probably isn't that important in the grand scheme of trauma. And really there was no difference in most of the other studies. So in the Danish registry study, so that's the fourth one there, they looked at perforated peptic ulcers. There was no difference in mortality between obese and non-obese. And then the Ferrada study, which is the second one, they looked at obese. So obesity per se didn't increase your risk, but being obese increased your risk of having diabetes and cardiovascular disease beforehand, and that increased your mortality. So I think it's important to know your patient's baseline background history. I think all of you are well aware of the metabolic syndrome, and I think that's probably one of the big things around obesity. In the acute surgical phase, risk of DVT and PE, and again, I don't think this is anything new. One of the challenges for us as physicians is how do you dose their anticoagulants? Do you dose on lean body weight? Do you dose on actual body weight? The ceiling dose of Clexane supposedly is 100 BD, then it became 150 BD at some stage. And then trying to dose heparin, trying to get blood tests, that can be really challenging. Also, I think the risk of MI is probably not linked to being obese per se, but I think if you've diabetes and known cardiovascular disease, and if you've had an emergency surgery, you can imagine there's an increased risk. To go back to our first case, obstructive sleep apnea, while everyone knows there's a clear association between increasing BMI and obstructive sleep apnea, there's almost no literature on emergency surgery. Most of the literature is on elective patients. And there's some emerging links between obstructive sleep apnea and post-operative complications, and that's higher reintubation rates, higher risks of arrhythmia, and chances of returning to ICU are higher in this group as well. So the stop-bang questionnaire, I don't know if any of you have heard of that. That has been validated in the perioperative setting. So it's a screening tool for moderate to severe obstructive sleep apnea, and it's estimated that about 25% of patients will screen as high risk. But of those, 80% will have it. So you've got a quarter of your patients who'll be high risk, and then only 4 out of 5 of them will have something. But again, it's important probably to consider, because while in emergency surgery you can't necessarily do something about the sleep apnea before they need an operation, it's important to be mindful if they have sleep apnea, to consider that when they have their emergency surgery. And that's the stop-bang questionnaire. So if there's anyone in the room getting worried, you have to have a score between 5 and 8. And I think that's pretty quick. Like most people could do that in under 30 seconds. Probably in the post-operative phase, if someone is already on CPAP, get them to bring it in, even if they're in because they've had emergency surgery. ICU use CPAP all the time and positive pressure, so it's going to be less pressure than on your surgical wound than ventilating them. And also one of the other things is maybe looking at minimizing systemic opioids use, so looking at regional blocks. Could they have an epidural? Would that make it better? Can you minimize the amount of Targen or morphine that they get? And then finally, to talk about obesity in the elderly. So I don't know if any of you have heard of the obesity paradox in the elderly. That's essentially where patients that are more than 75 have a lower risk of dying from cardiovascular disease than those, so obese patients, than those who are thin. But it is a U-shaped curve, so it's really bad to be underweight. There's a nice kind of normal area which includes more obese people than it does for those that are younger, and then it goes back up again. And there's multiple theories why that is. One theory is that, well, maybe the younger obese people who had lots of complications have died already, so they're not actually available to be included. And maybe the older fat people actually have a survival advantage. Also, the lower BMI includes those who have lost weight from disease. So maybe if you're thin and older and have always been thin versus you're now thin, older, and you've lost a lot of weight recently, they're all included in the same group. So it may not be quite as straightforward. And I think the relationship between those that are fit overweight, if you want to call it, and the sarcopenic obesity. So sarcopenia is a term you might hear geriatricians use. It's the age-related loss of skeletal muscle. So when you look at your older patients and they have pretty much no muscle on their arms, they have no quadriceps muscle, they're generally sarcopenic, and it's often linked to the frailty syndrome in older people. And I think really, like a lot of medicine, is turning out to be your functional capacity, and your functional status is probably a much better marker. So if, your 85-year-old patient can go, she might be obese, but if she can walk herself to the shops, walk around the shops, carry her grocery shopping back in and climb up her 14 steps, she's probably okay. Whereas a lady who can't shower herself, that's different. So I think the paradox is actually the wrong term in this. I think there's probably some other easier explanations, but paradox sounds nice. And so just to summarize, because I've tried to keep this a bit shorter, obesity is a spectrum. And I think we're almost shocked now, I think most of us are used to working with people whose BMI is up to 35, 40 pretty comfortably. That's almost normal. Whereas the super obese, I think the people who weigh 200 plus kilos are the ones who really fit into the category of where stuff starts to go wrong from obesity. And those on the lower end of the obesity spectrum who don't have a metabolic syndrome, they generally do fine. Those who are severely obese, who have complications like diabetes, have had toes chopped off, have recently seen a cardiologist for an angiogram, they generally have poor outcomes. But I think, especially if you're old, being underweight is really bad for you. And I think most of you would see that across your work. And I suppose the crux of the matter is it really depends on what's wrong with them. If you're going into emergency surgery with someone who's had fecal and peritonitis and is septic and is crashing, well then that's going to be a much bigger marker of their outcome versus someone who's got a small bowel obstruction that you're prepared to sit and wait a few days. And then finally, I put this in. I put in most physicians don't bite. Zenny is up in the back here, who's a peri-op physician in PA. I think one of the things that surgeons and physicians have done badly for years, so this is my little soapbox, and Brian knows I like soapboxes, is that I think surgeons and physicians need to work together. You are now seeing the people who are coming in who have a small bowel obstruction are not fit and well 50-year-olds who just happen to have a small bowel obstruction. There's someone who's had 10 surgeries. They had their angiogram and a stent put in last week, or they're falling at home, or they have early signs of dementia. They are unwell people. Older people are our core business in hospital. And I think the best outcome for patients is where physicians and surgeons can work together collaboratively. And I don't see my role in Logan as telling the surgeons they can't operate. It's a surgical decision whether someone needs an operation and what operation they need. But I think you can make a more informed decision if you're, wondering whether to take someone to theatre who's, got fecal and peritonitis. If they really haven't been able to get out of bed, don't leave the house, and can't shower or dress themselves, their chance of coming out of that surgery unscathed is pretty much zero. So your talk should more be about appropriate palliation and management of them rather than doing surgery and kind of being in the same situation 5 days later. But I think it's a collaborative, and one of the things Brian did when I started in Logan is I sit in the division of surgery and I sit in the surgeon's office, which keeps Tony occupied. But I think it really creates collegial bonds between people, and I think I have a lot of informal discussions with my surgical colleagues about people, and that really works well as well. So I think we're going to have to learn to work together even if we didn't in the past. So sorry, your patients are going to be like our patients. So any questions? And I hope I didn't talk too fast, because my accent gets very strong.
No, that was perfect. Aisling, thanks for keeping to time so well. Any questions?
Any questions on old people in surgery? Because I like those questions.
Just for further information, Aisling doesn't bite much, but
just a little.
You just have to be aware of it.
I do talk a lot, though.
All right. Well, thank you very much, Aisling.
Thank you.